I'm really honored to be here. Thank you, Tracy, for inviting me to speak again. I've done this before, different talks. I truly am honored to be here. I think this is an amazing conference that brings together, families and scientists and professionals and industry. And I think this is the space where we can, we have all the stakeholders we need to talk about where we need to go to make improvements. And so I'm truly honored to be here. I have the challenge of getting everybody on the same playing field. So my job is to kind of do a survey of Lennox-Gastaut syndrome so that you have the basis to sit through the rest of the talks. And it feels to me a little bit like a one-size-fits-all t-shirt. It may not fit for everybody. So I know some of this is going to be review for some people, and then some new material for others, depending on what your perspective is. So I apologize if I'm being redundant for some people. So Lennox-Gastaut 101. So I do actually have some disclosures. I do participate in research. I also have a lot of experience with both Lennox-Gastaut and Dravet syndrome, and so have done consulting with some of our industry partners, and have also been on a DSMB. I don't think that this influences anything that I'm speaking about today, but please let me know if you think that I did so I can correct the record. So I'm going to start off with defining Lennox-Gastaut syndrome, and then I'm going to talk a little bit about how to make the diagnosis. And then we'll talk about etiology or causes, and then move on and talk about some treatment options, and hopefully end with some ideas of where we should go next. So this is sort of the textbook definition that we use for Lennox-Gastaut, an age-related developmental epileptic encephalopathy characterized by multiple seizure types, characteristic EEG findings, and cognitive impairment. And I think the bullet points, multiple seizure types, EEG findings, cognitive impairments is, relatively straightforward. The other portion is sort of medical language. And really what we mean by this is that this is something that we see as children get older. So it's an age-related disorder that develops over time. And encephalopathy means the brain isn't working the way that it should. And we think that this is in large part due to seizures. So that's why we call this an epileptic encephalopathy. This definition has evolved over time, and it wouldn't be appropriate to give a 101 talk without giving you a little bit of history behind this. So in 1950, Dr. Lennox and Davis correlated seizure types and intellectual disability with the EEG pattern that we see with Lennox-Gastaut. Dr. Dravet, who is the same Dr. Dravet of Dravet syndrome, actually published the description of the syndrome in 1965. But she didn't get a lot of credit for it, but that's okay because she has a different syndrome named after her. And then Gastaut actually published something that he called Lennox syndrome with 100 cases. And then Niedermeyer, who has essentially written what at the time was sort of the textbook Bible of epilepsy, put this together and called it Lennox-Gastaut syndrome, giving both Dr. Lennox and Dr. Gastaut credit for describing this syndrome. And that's the name that we still use today. The International League Against Epilepsy started including this in 1989, so it took about 20 years before there were some international recognition by our professional societies for this. And then in 2006, ILAE included this as one of our epileptic encephalopathies. And that really just, was because of our better understanding of how this may develop over time, and also incorporates this idea that if we can control seizures, maybe we can make things better from a functional standpoint. And so that was really when we started to understand a little bit better this idea of epileptic encephalopathies and seizures causing overall dysfunction outside of just the individual seizure. This is our current definition. This was most recently updated in this last year, and really has some criteria for making a diagnosis as well. We like to see multiple seizure types. Drug resistant is in this definition right now. I actually would like to see a day where we can take that out because it would be really nice to think that we could actually treat this and that we don't have patients who are drug resistant. The onset needs to be prior to 18 years of age. This is in recognition that while the vast majority of people with Lennox-Gastaut present in the first decade of life, there are a handful of people who evolve into Lennox-Gastaut in adolescence, and so we've included them into this definition now. We have made a criteria that you must have tonic seizures, and I'll talk a little bit more about that. We also require that we see cognitive and behavioral impairment, but it's really important this may not be present at seizure onset. This is something that we see evolving over time. So I really want to make sure that we're not hearing that people aren't getting this diagnosis because they look too good to have Lennox-Gastaut. This has happened with some of our other epileptic encephalopathies where families don't get a diagnosis early enough because everybody thinks they just look too good. They can't possibly have that. And then there's characteristic EEG findings with diffuse slow spike and wave and generalized paroxysmal fast activity. And I'm going to show these to you here shortly so that you know what that looks like. We do see a lot of different seizure types with Lennox-Gastaut, and they may change throughout the lifespan as well. So just when you think you have a handle on the seizures that you're seeing, you may see other seizure types emerge. Most commonly, we see tonic seizures. Atonic seizures are very brief seizures, but often associated with an abrupt fall to the ground. And so while they are very short seizures, could actually be some of our most dangerous seizures, depending on where you're located when that happens. In my office, like most medical offices, we do not have carpet because that would be a little gross. And so we have hard tile floors, and that is a really dangerous place to have an atonic seizure because our floor is not forgiving. We see myoclonic seizures, which are quick jerks, and sometimes those can also lead to a fall. We can see atypical absence seizures. These are typically when people are staring off into space or may have some brief behavior arrest. These can be really challenging to capture because they can come and go so quickly. And so you may just see a slow decline in function and not a clear onset and offset to that seizure, and can be very difficult to count. And we can also see focal seizures, particularly depending on the underlying etiology. So lots and lots of seizure types. The tonic seizures can actually be quite subtle and may be only present during sleep. And so it's incredibly important to get an EEG, preferably a video EEG during sleep, to look for this. Otherwise, it may be missed. And it is very challenging as a parent because oftentimes we may be telling you your child's having 7 to 20 of these an hour while they're sleeping. And when we look at the video, it's really, really subtle for you to pick that up. And I can only imagine as a parent to be told that your child is having these very subtle seizures so frequently during sleep must be terrifying. Because you really want to keep track of these seizures and make sure that you're managing them. So sometimes EEG really is the best way to follow these, and I'm actually going to give you an example of a study that demonstrated this. So I'm going to move on to talk a little bit about EEG, and I imagine that many of you have sat through many EEGs. We saw a video EEG, a picture from a video EEG from Charles Wagner just now. And this is what a normal EEG looks like. So it really is a bunch of squiggly lines. This is a completely normal snippet of EEG that I'm showing you right here. And this is what EEG looks like in Lennox-Gastaut. So on the left-hand side, we see slow spike and wave. And so, you see these sharp, pointy things that you wouldn't want to sit on. And there, you can see that the waves are much wider than what we saw in that normal EEG. And that means that each wave is taking a longer period of time, and therefore we call it slow. So slow spike and wave. And then on the other side, on the right-hand picture, on the far right of that picture, you see what kind of looks like this crazy, chaotic pattern. And that's actually a tonic seizure. That's typically what we see with a tonic seizure. And that's also called generalized paroxysmal fast activity, or PFA, that we see. And these are the two things that we look for in children with Lennox-Gastaut. So for those of you who haven't previously looked at your children's EEG, this is what we're watching for. So let's talk a little bit about the prevalence of Lennox-Gastaut. And honestly, we don't have a great answer for this question, and to answer this question. And I think this is probably an area where we need to circle back and do a little bit more work because the data that we have is really pretty old. And so we're kind of making a guess at how many people have Lennox-Gastaut. We typically see onset before 8 years of age. The peak onset is usually between 3 to 5 years of age, but as I mentioned, we can see onset in later adolescent years. There have been some rare case reports of evolution into Lennox-Gastaut in adulthood, but that is really pretty rare. We see a very wide variation in prevalence estimates, anywhere from 1 to 10% of childhood epilepsies, and that's really pretty broad, and it would be really nice if we can narrow that down a little bit more. Probably one of the best studies estimates that the prevalence is around 4%, but the study is actually quite old. This was done in the 1990s. And actually, this is before we really had regular use of video EEG. Video EEG was really just emerging at that time. We certainly did have video EEG, but it was actually on VHS tapes. Storage was hard. Collecting all of that data was very challenging, and it wasn't something that every patient with epilepsy received. And so I'm concerned that this probably vastly underestimates the amount of Lennox-Gastaut, because many patients probably weren't getting overnight EEGs during this time to meet the criteria for Lennox-Gastaut. One of the most important things to understand about Lennox-Gastaut is that it evolves over time. And this is a slide that I don't know if Tracy made, but came from the Lennox-Gastaut Foundation. And I could probably just stand here and have this slide and talk for an hour about Lennox-Gastaut, because I think it really summarizes everything that you need to know about this. Starting on the far left is etiology, and there are lots and lots of reasons why people can have Lennox-Gastaut. And that etiology usually precedes the first seizure or could be associated with the first seizure. Some of these things are things you have through a lifetime. Obviously, an injury is something that happens at a point in time and may have a seizure associated with it. And all of your children have had a first-time seizure. And whenever we see that first-time seizure, we don't really know who will go on to have more seizures and who won't. We can make some educated guesses, but we don't have crystal balls and we can't predict that perfectly. Once you have a second seizure, then we say that you have a diagnosis of epilepsy, and we do work very hard to try and figure out why that's happening. That epilepsy may evolve into drug-resistant epilepsy and may actually meet some other criteria for other types of epilepsy syndromes, one of which is West syndrome or infantile spasms. But not every child with Lennox-Gastaut has infantile spasms. They may have other types of diagnoses. They may simply have focal epilepsy. They may have myoclonic astatic epilepsy, or they may have early infantile epileptic encephalopathies. So lots of other epilepsy syndromes that get diagnosed. And then over time, we see this evolution into Lennox-Gastaut, where we start to see multiple seizure types emerging. We start to see these characteristic EEG findings of slow spike and wave and paroxysmal fast activity. Typically at that point, we have cognitive impairment, although not always. So it's always important to keep that in mind, that may actually present a little bit later, although for most people it presents prior to this diagnosis of Lennox-Gastaut. Onset is usually before, as I mentioned, usually before 8 years of age. And over time, we see that the vast majority of people with Lennox-Gastaut continue to have seizures. Greater than 90% will continue to have seizures. Greater than 95% will have cognitive impairment. There's a greater risk of death associated with Lennox-Gastaut. We see a significant amount of people who experience status epilepticus. And one of the talks later throughout the session is on seizure action plans and emergency medicines. And I think that's an incredibly important discussion to have, because everybody should have a seizure action plan, whether you go to school or not, so that people know what to do if there's an emergency. We estimate 40 to 50,000 cases in the US. We don't really know if that's right. As I mentioned, we're still not really clear about the prevalence, and it may be far greater than this. So this may be an underestimate of how many people are impacted. And I'm not really good at estimates, but I'm pretty sure there are not 40 to 50,000 people in this room. So clearly we need to reach out to more people to make sure that people know that the foundation exists and that you guys are here to support each other and to work through this. So we have a lot of work there as well. Over time, we see these developmental delays emerge. And I'm going to briefly talk in a couple of slides about what we think may be sort of a common pathway for this. But we think one of the reasons why some children develop Lennox-Gastaut and others don't is that there's an issue with how the networks of the brain are working together. and that they develop a maladaptive network. And that's probably something that evolves over time as these symptoms are presenting with Lennox-Gastaut. As I said, I could probably just keep that slide up and keep talking. Circling back to EEG, one of the things that I would be, as a physician, would really like to be able to do is predict who is going to develop Lennox-Gastaut, because it's really challenging. We are not very good at that. And there are some populations where we may actually have, may be able to target to try and figure that out. And one of those is our patients who present with infantile spasms. We typically see infantile spasms in the first 1 to 2 years of life, really most often in the first year of life. And we know that a percentage of those children, probably about a third of them, will evolve into Lennox-Gastaut. And wouldn't it be great if we could identify those children that were going to evolve into Lennox-Gastaut and intervene before that happened? Now, I don't know what that magic bullet would be to intervene with, but the fact that we're still not able to predict who will evolve means that it's really challenging for us to think about how to intervene at that point. But it sure seems to me it would be much better to intervene before you have Lennox-Gastaut than after we have this diagnosis. This group actually followed EEGs in children with West syndrome as they evolved into Lennox-Gastaut. And again, they found that about a third of patients developed Lennox-Gastaut. That seems to be pretty standard. Our old literature supports that, and some of our newer literature supports that as well. In this particular population, most of these children transitioned into Lennox-Gastaut over a period of about 17 months, and the age of transition was around 17 months. So a relatively early presentation, not the children who are evolving later on at 6 or 7 years of age. What I think is most frustrating, I think they have done great work, but what is frustrating to me as a provider, they were able to group these into 4 different groups of patterns that they thought they saw that evolve into Lennox-Gastaut. But quite frankly, they see all of the abnormalities on the EEG in the children who evolved into Lennox-Gastaut. And so it's not really a clear pattern for me to look at, other than if the EEG continues to look crummy, that's a kid I need to worry about. And so, that was something I kind of knew already, that if we didn't normalize your EEG, if you weren't looking great, if you were continuing to have cognitive development issues, that I needed to worry about you. And so this doesn't really answer our question of who should we worry about. It tells me I need to continue to worry about all of my patients with infantile spasms, particularly if their EEG is abnormal. Another challenge for the medical community are those adult patients who may or may not have had a diagnosis of Lennox-Gastaut. And I will tell you, not everybody who has Lennox-Gastaut is getting diagnosed with Lennox-Gastaut. We actually see this at my own institution. We recently reviewed our patients with infantile spasms and went through their charts to see how many people had been diagnosed with Lennox-Gastaut. And the vast majority had not, even though they met criteria. Now, it wasn't that they weren't being treated properly. They were actually getting a more specific diagnosis, and people weren't using the term Lennox-Gastaut with those families. And that is a bit of an issue, because that means that when our families are going out on the internet to look for support, they're not finding you. They're not finding the Lennox-Gastaut Syndrome Foundation. And so it's really important that we let them know that they also meet criteria for Lennox-Gastaut, and I'll circle back to that as well. And this is a problem when our patients transition into adult care. If the adult neurologist now does not know, did you or did you not have Lennox-Gastaut? And that may be important for participation in research studies, and also to think about management. And so a group came together to try and think about, how do we do this, and how do we assess these adult patients to see if we think they may have had Lennox-Gastaut. And so they went back to the basics that every physician should be doing: history and physical exam. And the most important part of that is a past medical history, looking at multiple seizure types. What age did those seizures start? What's been the history of the development? Looking for, on physical exam, for specific diagnoses. And also looking back at the medical records to see if there was a case report or a summary. Has anybody mentioned Lennox-Gastaut? Do we have EEG findings? And I had to split this up into 2 slides here. And the question is, did you have enough evidence? Actually, let me see if I can go back. the question is, do you need more to make a diagnosis of Lennox-Gastaut in the adult patient? And so if you have good records and you had good care prior, you probably don't need any more information, and we know that that adult has Lennox-Gastaut. But sometimes maybe that didn't happen, and so what should happen next with that? And this can be a little bit tricky because some of those EEG findings may actually change over time and may not be as reliable in our adult population. They do recommend obtaining an EEG, and if you have a normal EEG, it is very unusual for somebody with Lennox-Gastaut to have a normal EEG, and so we would say that person probably does not have Lennox-Gastaut. If we see clear slow spike and wave and paroxysmal fast activity, it's pretty clear that person does have Lennox-Gastaut. The question is for that middle group, what if you're not sure on that routine EEG? And their recommendation is to go on and do more video EEG monitoring to try and sort that out, to see if you can sort out whether this adult patient may or may not have Lennox-Gastaut. Now, my hope in a perfect world is that our adult epileptologists don't have to do this work, because my colleagues and I should have done this work for them before that. But unfortunately, that's not always the case. And I think particularly for adults in our population or families who are suspicious that their adult children may have Lennox-Gastaut, this is an important process to go through. This is one of the things I said I would circle back to. I think it is really important that everybody should have a diagnosis of Lennox-Gastaut, who has Lennox-Gastaut, secondary to something else. Lennox-Gastaut is a syndrome. It's not an etiology, it's not an explanation, it's a common final pathway. And it's really important to figure out what is that secondary to, because there are lots of things that cause Lennox-Gastaut syndrome. And we know that about 75% of families living with Lennox-Gastaut, that there's something causing that symptomatic, whether it's a neonatal encephalopathy that happened previously, a cerebral malformation, or genetic underpinnings of that. A large percentage of children will also have a history of infantile spasms, as I had mentioned before. These genetic contributions are becoming more and more important. The neonatal encephalopathies, those are things like, trauma around the time of delivery, bleeding, things like that happen in the early neonatal period. Cerebral malformations can be diagnosed with imaging, so those are also pretty straightforward. That leaves us with a group of children who have relatively normal MRIs, no clear history of trauma or something that may have led to their Lennox-Gastaut. And I think the vast majority of these children probably have genetic contributions. And you're going to hear even more about this in one of the next talk after me, actually. And we have a growing list of genes in individuals who have Lennox-Gastaut. And it is really important to get this genetic diagnosis because it may actually impact how management occurs. We know some of these genetic disorders may respond better to one medication than another. Some classes of medications may actually make seizures worse for that particular diagnosis. And so it's incredibly important to get this genetic diagnosis. This is from one of my colleagues at CHOP, Ingo Helbig, and it's a little bit old. It was published in 2016, but I think this actually is a good pictorial of what we deal with genetic diagnoses. And really what you see over time is that, in the more recent history, we've had this explosion of genetic diagnoses that we now know are associated with epilepsy. And this curve is actually getting even steeper and steeper. Previously, people used to kind of have a running list of the genetic things that we could test for that were associated with epilepsy. And I don't think I could even contain that to slides that I would present. It would just be, alphabet soup after alphabet soup after alphabet soup. But it, really has improved our understanding of what is causing Lennox-Gastaut for a number of our patients. So moving on, we know that Lennox-Gastaut isn't just seizures. That's mostly what I've talked to you about so far is cognitive issues and seizures, but there are a lot of other things that go along with this. And all of these things really impact quality of life. And when I talk to families, sometimes when I talk to them, seizures may not be the most important thing at that visit. It may be the fact that their child isn't sleeping, or their child isn't eating, or their child's behavior is interfering with everybody else in the household. And I think it's really important to keep track of these and understand that this is a syndrome that is more than just seizures and cognition. It's all of these other things. We need to consider these comorbidities when we're choosing anti-seizure medications. Polypharmacy is sort of the mainstay of managing somebody with Lennox-Gastaut, so multiple medications. But some of our medications may make some of these comorbidities worse for you. And so it's really important that we recognize that and that we know about those comorbidities. Maybe your child is overweight because you can't contain their eating. And so putting you on a medication that makes somebody more hungry is not going to be the best thing. Or maybe your child struggles with eating and putting you on a medication that limits your appetite is going to be a problem. And so those are things that we really need to think about. This is data that comes from you. And these are the major issues that were reported by Lennox-Gastaut syndrome caregivers. At the top of that list is seizures, and I think, as we've mentioned in our prior slides, greater than 90% of people with Lennox-Gastaut have ongoing seizures. But right below that are sleep disturbances, and boy, when your child is not sleeping, that means parents aren't sleeping either. And that means that it's really difficult to function the next day. And that's fine for one night. I'm a physician, we take call, every now and then I have a night with no sleep. I can't imagine what that's like night after night after night after night, and has impacts on everybody in the household depending on what that looks like. Injuries are pretty significant from seizures in children with Lennox-Gastaut, in particular because those seizures associated with a fall, whether they're atonic seizures or tonic seizures, are pretty frequent in this patient population. And so, protecting your children from hitting their head and developing a subdural, knocking out teeth, I know is something that everybody struggles with. Developmental delay has all of its issues. It's difficult to know what is bothering your children, and you guys are really good about understanding your children, but sometimes it's really hard to figure out what do they need from you today, what's making them uncomfortable. Behavioral issues can create problems, particularly with siblings. It's not, and you guys have to tell me, but it's not uncommon that I hear in my office that when we see aggressive behavior, that it's usually targeted to one person in the family. Most often, what I hear in the office is it's usually mom or one of the siblings that is targeted with aggression. Sometimes it's the whole family, and that can be really challenging when you're trying to keep people safe, particularly as your children get bigger. And I have 3 boys, and they are all a foot taller than me. So, that can definitely be a challenge. Using a wheelchair is a challenge. While things are adapted much better for wheelchairs, it still is a challenge to figure out how to get in and around places, how to move that wheelchair around. Most of the children are not able to read, can't write, are nonverbal. These have their own unique challenges. Hospitalized at least once a year. 50% of families spend at least once a year in the hospital. That's incredible, and that is really disruptive to everybody's life when that happens, not to mention scary, and you're there to address an urgent medical issue. And a large portion of families are G-tube fed. In this survey, people went on to rank what was most important to them. Just because you have it doesn't mean it's the top thing on your list to be concerned about. And of course, the top thing is seizures and safety. Developmental and intellectual impairment and communication were the second most important thing, aggressive behavior, mobility, and sleep. Not to mention cost and access to care and social isolation. I mean, these are huge issues that we need to try and figure out how to manage. So let's talk a little bit about intellectual impairment. So etiology may make a difference in children who have intellectual impairment, and I think also when we know the underlying cause, we can give you a better idea of what to expect in the future. So when we look just at etiology and who has a known etiology and an unknown etiology, those with unknown etiology, about 43% have severe intellectual impairment. Those with an identified etiology are much more likely to have severe intellectual impairment. And so, but again, having that specific diagnosis can help us better predict what to see in the future. This was a survey that was done by one of my colleagues, Ann Berg, again, a survey of you as a population, and found that 19% of children with Lennox-Gastaut have difficulty sitting independently. Another 12% are able to sit but not able to stand. 12% are standing independently but need help with walking. And almost 40% are able to walk independently, but most of them needed support on stairs. In some ways, these all have different management issues, right? A child who has difficulty sitting, that is a lot of burden for the caregiver to make sure they're safe, move them around, and manage that. But in that most functional category, walking independently but needing support on stairs has its own challenges as well. And this is a really dangerous situation for some of these children. It means you have to watch them all the time because if they have access to those stairs, they could fall and get injured. And so each of these has their own unique challenges, and that's independent of seizures. We also see a higher rate of death in this patient population. It is hard for us to talk about this. I know it's hard for you to think about it and talk about it as well, but I think it's an important thing for us to acknowledge. At the top of that list is sudden unexplained death in epilepsy patients. We also see children who die of status epilepticus. We can see injuries from seizures that can lead to death, and we can see respiratory events, thus all the masking that we're doing still in the pandemic to keep everybody safe. Children with Lennox-Gastaut are 14 times more likely to die than children with other types of epilepsy. So let's talk a little bit about this common pathway. I've talked about all of the different etiologies that we can see. We've talked a little bit about the comorbidities. I'm just going to give you a little bit of sampling about the common pathway. I think somebody else is addressing this later on in the conference. This is a picture of the brain. I suspect most of you were able to recognize that. I apologize if this is overwhelming to some. These deeper structures, and I'm not sure how to use my pointer, but I put boxes around them. The thalamus, which kind of sits in the middle of the brain, the cerebellum, which sits at the back of the brain, and the pons, which is part of the brain stem, are areas that we know are involved in Lennox-Gastaut. In some ways, this is a little bit perplexing to us as epileptologists and basic scientists because we think of seizures as coming from the cortex, the outer layer of the brain. But these deeper structures are also relay areas for seizures and appear to be significantly involved in some of the abnormal pathways that develop in Lennox-Gastaut. This is an MRI of the brain, and what we see in this MRI, and I'm not expecting people to really read this, it's really to get the overall sense, is the red areas are areas where in patients with Lennox-Gastaut we saw increased activity compared to healthy controls. And you can see the sort of red blobs at the back and bottom of the brain. That's the cerebellum, which we're seeing much more activity in children with Lennox-Gastaut than the general population. And then the cortical areas are the outer layer of the brain. And here we see it in blue because we actually see less activity than what we would see in healthy controls. And I think this is particularly concerning and also explains some of what we see with our symptoms because these are the parts of the brain that we use for thinking and planning. And these are the parts of the brain that are not working as well in children with Lennox-Gastaut, giving us this epileptic encephalopathy that we see. So that was just looking at what parts of the brain are working as well or not as well as healthy controls. This actually is some studies that were done to look at, how is the brain working in different parts? How are the networks working? Because those cells don't work in isolation. They connect to other cells and produce the function that we see in the brain. And what we see here, and I know this is a complicated slide, but really the takeaway is that the brain in Lennox-Gastaut works different than healthy controls. And what we see is that these blue pathways are pathways that are typical networks that we would expect to see working together in the brain when we do functional MRIs. And in Lennox-Gastaut patients, these networks are not working the way that they should, and they're working at less we're seeing less impact in those pathways than we would compared to healthy controls. Whereas the red areas are connecting abnormal areas that are not usually working together in a typical network, in a typical person in healthy controls. And so we've developed these abnormal pathways in the patients with Lennox-Gastaut. And so this really was sort of the foundation of the idea that we have these abnormal networks that are working in Lennox-Gastaut, and parts of the brain are working together that really should not be working together in a typical brain. We do see some brain volume differences, and we see this particularly on the left side is the whole brain, and then on the right side are these areas that we're concerned about in the pons. And this tells us that there are brain volume differences in people with Lennox-Gastaut compared to healthy controls, which also gives us an idea of how the brain may be working. Interestingly, these changes are not related to age, so there are things, it tends to be present the whole time. So let's move on and talk a little bit about management. As most of you are probably aware, we have lots of medications that we can choose from to treat Lennox-Gastaut, but none of them so far has really turned out to be the perfect medication. This is a group of medicine that we actually have some phase 3 clinical trials to support the use of in Lennox-Gastaut, and many of these probably look pretty familiar to you. You'll notice that where some of the towards the bottom of the list, that many of these have been studied just more recently, whereas prior to that, there weren't really a lot of studies in children with Lennox-Gastaut. That doesn't mean that we don't use some of our older medications, and this is a list of treatments that often are used in Lennox-Gastaut and probably look pretty familiar to you. And some of these are our older medications. Some of these are not medications. They're treatments that, like ketogenic diet, vagus nerve stimulation, and surgical resection that we should also be thinking about in this patient population. I do want to just highlight a little bit some of our newest medications that have approval for use in Lennox-Gastaut. So this is CBD, Epidiolex, and I think there's actually a talk about this tomorrow, so I'm not going to spend too much time on this, but did want to demonstrate that there actually was a significant benefit in Lennox-Gastaut with this medication compared to placebo. I think it's also important, and probably more important for providers, and I'm probably preaching to the choir in this group here, but the outcome measure for this was drop seizures, and many people think of drop seizures as just atonic seizures, but in fact in these studies, drop seizures are any seizure that's associated with a fall, and that's really important for people to keep in mind. So this was not just those atonic seizures. This could be tonic seizures that lead to a fall, generalized tonic-clonic seizures that lead to a fall, and so it really is a broad spectrum of seizures that were used as the outcome here, and that has turned out to be a very reliable measure for people with Lennox-Gastaut, because counting seizures is a really challenging thing to do, particularly when you're having hundreds of seizures a day. Fenfluramine also received FDA approval in March, so very exciting to have this come on the market. And this again was studied in both low dose and high dose. At the high dose was found to be efficacious for people with Lennox-Gastaut. Again, they used the same outcome measure of drop seizures, which is any seizure associated with a fall. I do want to just point out a little bit that there was a breakdown in seizure types in some of the results that were presented, and we do see an improvement in generalized tonic-clonic seizures, both at the high dose and the low dose of fenfluramine. Also an improvement in tonic-atonic seizures, as well as tonic seizures. Well, those atonic seizures did not really have a significant response to fenfluramine, and so that may be important as a family when you're thinking about the seizure types that you're trying to treat. Fenfluramine and CBD actually had similar response rates, both in 2 studies for Epidiolex for CBD, so that was consistent. There was a phase 2 trial with a new product called Soticlestat. I think I'm saying that right. It's a little bit of a tongue twister to me, which actually is going on to further trials, which did not find significance in their initial trial, but had a somewhat similar decrease in seizures. And so I think we look forward to see what that may look like in the future. So that is yet to come, and some of you may actually be participating in some of those studies. I just wanted to give you a little bit of data about the across all of these randomized control trials, because selecting a medication is really challenging because we have so many options and none of them are quite perfect. And so this really is something that I feel needs to be an ongoing conversation between you and your provider. And one of the things that I tell my families is you probably will end up using all of these treatment options in your lifetime. The question is, what's the best one to use right now with your situation, looking at quality of life, potential side effects, and seizure types that you're having right now? So I think that's really important to keep in mind. And so there are a number of medications here, and you can see that the reduction in drop seizures, and again, for most of these, that's the broader drop seizure, any seizure associated with a fall, are actually pretty similar across these. It is important to also look at placebo rates. Some studies have a higher placebo rate and some studies have a lower placebo rate. This is something for those of us who do clinical trials that we have to make sure we account for, and it's really hard for us to explain what that placebo rate is, but it's important to keep that in mind as you're looking at some of these as well. And then I just want to also mention that all of these have safety findings. Every medication that you take, any treatment that you take has side effects, and it's always important to discuss those as well, because sometimes that side effect may actually be something that is a benefit to you. And it's quite possible that that side effect may actually could be a problem for your quality of life as well. And so it's important to think about those things and look at that as well. So I just want to make sure that we mention that. This is also a different way to compare anti-seizure medicines and Lennox-Gastaut. And here you can see across these, in the green, we have Epidiolex, we have rufinamide, also known as Banzel, in purple. The green is clobazam. It's hard for me to see, which sadly means it is probably hard for you to see up there. I apologize for that. CBD is in the dark blues. We see a CBD clobazam combination in the lighter blue, topiramate, and then fenfluramine in the yellow. And so this is another way to kind of look at this to help choose a medication. Somebody had a really brilliant idea of collecting all of our treatment guidelines to see if there was some consistency about what people recommend for treatment in Lennox-Gastaut. And these treatment guidelines, some of them were published and some of them were institutional guidelines. They reached out to get a broad array of treatment guidelines and then assess this to see what was consistent about these recommendations. And these findings are not really surprising to me. The medications that I use more commonly in Lennox-Gastaut were the ones that were more likely to be recommended. So Lamictal, topiramate, rufinamide, valproate, clobazam, ethosuximide, which was a little bit of a surprise to me, clonazepam, all on that higher end where there was a lot of consistency with treatment guidelines. On the red end, these are sort of the no-go medications or things that were explicitly not recommended, we're told to avoid. We see some things that I was a little surprised, quite honestly, as a pediatric neurologist, because I don't really say no to most medicines. The vigabatrin was in that group, which I probably would disagree with. Tiagabine, which I don't think I've used in the last 20 years. Gabapentin, pregabalin, oxcarbazepine. These probably are medications that we should use with some caution because they may actually worsen tonic and atonic seizures in some patients, but in some patients they may be helpful. And so I'm not sure I would definitely say a no-go on these medications. I would just say proceed with caution. But I think this probably reflects what most of us think about in practice. I had mentioned that we have some non-medication things to think about as well, ketogenic diet and VNS. And here's some data on the top supporting the use of ketogenic diet in children with Lennox-Gastaut. And then we also have some efficacy studies with vagus nerve stimulation suggesting that these would be helpful. And I think it's always nice to see that, particularly in the ketogenic diet, there's this group of patients that are seizure-free or nearly seizure-free. And that's something that we always hope for and we don't see very often. But I think that's a really important thing to keep in mind. And unfortunately, for most of our patients, we don't know if you're going to fit in that category until you try it. And so I think as a family, you have to keep this in mind as you're making choices, that you may have to just jump in and give this a try to figure out if you might be in that small percentage of people that are seizure-free or nearly seizure-free. Just to quickly review ketogenic diet, although I imagine most people are familiar with this, the ketogenic diet is a diet that's high in fat, low in protein and carbohydrate. And so in the top, we have sort of our typical American diet, where we usually eat about 50% carbs. If I had my choice, it'd be even more carbs than that. The Atkins diet, which actually is something that we do use for management of seizures, significantly reduces that amount of carbs. The classic ketogenic diet increases the amount of fat and reduces the carbs and protein. And then we also have an MCT oil version of ketogenic diet, which is really a type of fat. So it kind of gives you a sense of the ratios that we see, just to give you a typical sense of that. And for those of you who may not be familiar with VNS, this is a device that goes underneath the skin. It gives an electrical discharge. We can program how much current is in that, the duration of that discharge, and the frequency of that discharge. So this is typically a day surgery. You come into the hospital, you get the device placed, you get to go home at the end of the day, and then we use a wand over the device to make adjustments to it, for those of you who may not be familiar. We have some other epilepsy surgeries. Corpus callosotomy, which our first speaker talked about, is something that can be particularly helpful for atonic seizures. We don't have great data on this. There are a lot of papers out there, but it's kind of variable what the outcomes are, and people use lots of different definitions for their outcomes. It is well tolerated, and for some families, this leads to a significant improvement in seizures. And you can see here that we have some reported seizure freedom rates when they're looking at atonic seizures of close to 50%, which is really kind of exciting. Resective surgery, this is where seizures may be coming from one part of the brain, and we can actually remove that part of the brain and hope to make seizures go away. There's lots and lots of case reports and small series that demonstrate seizure freedom after surgery, and some of those can be as high as 60%. And so for children who are candidates for this, this is probably one of the best treatment options, but it's something that is only available for a small group of patients who may have that focal etiology to their Lennox-Gastaut. And the best candidates are those who have a focal abnormality on MRI. I recommend that my patients get repeat imaging every 5 years or so, because our techniques are getting better and better over time to pick up some of these abnormalities. And certainly if you haven't had an MRI on a 3T scanner, it would be very important to do that, because that can identify things much better from some of our prior scanners that we had. The technology is just getting better and better, kind of like your cell phones. Technology is getting better and better over time. And what we do know is that the younger age at surgery seems to lead to more improvement in cognition, and that really is not so surprising. If we think that seizures are causing this encephalopathy, the fewer seizures you have, the less encephalopathy you'll have. And so that's not a surprising finding to have. And here we can actually see Cindy Keeter, who is from Cook Children's here in, sorry, I'm not sure if I'm in Dallas or Fort Worth, but she is in Fort Worth, not Dallas, at Cook Children's, pulled this together to look at some of these response rates. And angle 1 means that somebody's seizure-free. And so to see things where we see a 67% seizure freedom rate with a resective surgery is, really pretty exciting, and definitely an option that, if has not been explored with your child, you need to at least ask the question of why this wouldn't be an option for your child. So how do we put this all together? How do we pull all of these medications in, all of these different treatment options to figure out the best way to manage your child? And the truth is, I don't have the best answer for that, but I have some frameworks that we can look at. This was an approach that was published by one of my colleagues at Nationwide, Adam Ostendorf. And basically, the first step is making the diagnosis, so that is the most important thing. We've already been through how to do that. I agree with his approach that our next step is we need to look to see if you're a surgical candidate, because I just presented you data telling you that that is the most likely way that your child will be seizure-free. Obviously going through resective surgery, palliative surgery. And then the next step is really to think about what other medication can we add in. Unfortunately, the best management for Lennox-Gastaut really does appear to be with multiple medications. That's just a reality. I do think that there probably needs to be a limit on the number of medications that patients are on. My goal is usually no more than 3 medications. I prefer 2 if we can do that. What we start to see is as people are on more and more medications, we have so many drug interactions that we don't know if those medicines are helping each other or canceling each other out or actually making things worse. And, you know, I live in Colorado. About 7 or 8 years ago, we had a lot of people with Lennox-Gastaut syndrome move to Colorado. And many of the families that moved into Colorado came to us on 7 or 8 medications. And just by limiting the number of medications that they were on, we saw an improvement in some of their seizures. And so I think it's really important to make sure that the medicines that you're on are the medicines that you need to be on and that you're not on more than you should be. He gave a list of preferred medications. This looks pretty similar to what we saw in that prior slide where they looked at all of the treatment guidelines: clobazam, topiramate, rufinamide, lamotrigine, felbamate, levetiracetam, valproic acid. This was published before we had cannabidiol and before we had fenfluramine, because it's only been a couple of months. He also importantly put in here, enroll in a study. And I think that's a really important treatment option to think about. Studies aren't for everybody. You do feel like you lose a little bit of control because through the study, everything is by a protocol, and you're usually in that study for a period of 20 weeks or so, maybe a little more, a little less, depending on the study design. But those studies do potentially give you access to a treatment that may not be available to you for another year or 2 or 3. And typically when you go into a randomized trial, you do your randomized trial for your 20 weeks or so, and then afterwards you're able to opt to go into open label extension where you know you're actually receiving study drug. And so it may give you early access to something that potentially could be helpful. And so I think it's a reasonable thing to consider. Again, it may not be for everybody. It's definitely a choice to go into a study or not go into a study, but I think it can give early access to some amazing treatments. This is another opinion that actually came largely from a European group, but you can see here there's a lot of similarities. In their medication list, they have Depakote, lamotrigine, rufinamide, then topiramate, clobazam, and felbamate. They also list here ketogenic diet, resective surgery, VNS, corpus callosotomy. So all of the same things, and we kind of see this group of medications that probably are more effective than others. They acknowledged that CBD and fenfluramine were coming out and were probably going to be helpful. They weren't really sure where to put it in there yet because they were still in trials. This is actually recommendations for treating an adult population. And again, we see these same medications. And that really is sort of the take home of this, is there's sort of a theme of medications that may be helpful, more helpful for children with Lennox-Gastaut. It doesn't mean that you don't try the others, but it would be helpful. I would encourage most families to think about this first group of medications to make sure that you've tried those. The same group also talked about transitioning to adult care, which I think is an important thing to keep in mind. And I know that this is a really challenging thing to think about. I've worked closely with a group trying to figure out how to transition our Dravet patients into adult care, and have worked in a group with families, adult neurologists, and other people associated with the care. And it is a really difficult thing. You have a relationship with your pediatric neurologist, and you have hopefully learned to trust them. It should be a relationship of trust. If not, you need a new one. And it's really hard to establish that relationship with somebody else. And for adult neurologists, they may not be as familiar with some of our newer medications. Some adult neurologists are not used to talking to a family. They're used to talking to a patient, and your children probably are not able to advocate for themselves in that way. And so you need to find an adult neurologist who's comfortable in that situation, because if they're not comfortable talking to you, you're not going to be comfortable talking to them. But those adult neurologists actually do exist out there. Again, the management recommendations here were pretty much the same. And they also encourage the adult neurologists to think about these non-pharmacologic options if they haven't been used already. Ketogenic diet absolutely is available in the adult epilepsy world. It's not just a pediatric thing. VNS also available in the adult epilepsy world. Palliative surgeries can be done in the adult epilepsy world. So all of these things should still be options as you transition into adult care. I did want to just mention a study that was performed recently looking at DBS, deep brain stimulation. This was actually an adult study where they did bilateral implantation into the thalamus and did stimulation in that area. It was a double-blind study, so everybody got implanted, and some people had stimulation turned on and some people did not have stimulation turned on. And the outcome measures were seizures recorded in a diary, which is pretty typical for almost all of our trials. And they also did a 24-hour EEG. And so first of all, the most exciting thing is that they actually found benefits with this. So I think this is an exciting option that many centers are feeling more comfortable moving forward with. But I think the other really interesting thing with this is that when they looked at EEG seizures, they actually saw more improvement than what was reported on those seizure diaries. And at the beginning of my talk, I mentioned that it's really important to do video EEG to look for those tonic seizures because they may be really challenging for people to count and for people to assess how frequently they're happening, are they still happening? And I think what this demonstrates is that when you are counting the seizures that you're able to see, we are missing some of those seizures. But we have some options that may actually improve them, and this may be a really good outcome measure for us to look at. I would not really expect a placebo rate if we're looking at EEG, although I suspect somehow it will still happen because we have placebo with everything. But it seems like this would be a much better reliable way to do outcomes in people with Lennox-Gastaut. I think we're going to have to wrap our heads around this as trialists because it is challenging to bring you into the hospital and do this for 24 hours, but something important for us to look at. And then on the right side, you can see these graphs where how much improvement was seen over time. And so I think that was also quite exciting to see the improvement with this. So an exciting option. I also wanted to point out that I have mentioned quality of life earlier, and quality of life I think is something that we need to continue to think about. And we do see increasingly quality of life measures in the trials that are coming out. This is something I talk to people about in my office, regardless of the type of epilepsy that they have. Honestly, I can stop anybody's seizures by bringing them into the ICU and putting them on so much medication. But I have to do it in an ICU because you may not even be able to breathe on your own with that, and that's not good quality of life. And so while we are all hoping for seizure freedom, living in the ICU is not the place to do that. And I think this was a really very, very small study, but demonstrated that instead of looking at seizures, that we probably could look at quality of life and see improvement. And we can see here that the overall quality of life in this small group, that a number of these patients actually had improvement in quality of life on this particular medication. I'm not really advocating the medication. I think there's lots of other things that we need to look at with clobazam. I do like clobazam as a medication, but I think the most important thing is that we really should look at quality of life as an outcome, not just seizure frequency. So I kind of want to end on where we should go in the future. And you're going to hear some of these things that are happening throughout the rest of the conference. I hope I've given you a good baseline to move forward with the rest of the talks that are happening and a little bit of teaser for some of the things that people are going to talk about. But I do think there's lots of opportunities so that we can get to this place where our hope is seizure freedom and a cure. And I think there are a number of things that we can do in the short run that can get us closer and closer to that. So maybe this is our 20 hours a week of training for our Ironman. We need to figure out who's at risk. I can tell you that a third of my patients with infantile spasms are going to have Lennox-Gastaut. evolve into Lennox-Gastaut, but I can't tell you which ones yet necessarily unless I know their etiology. And so we need to continue to work at that. And that only accounts for, probably about a third to maybe 40% of people who have Lennox-Gastaut. So we have to figure out who else is at risk and how can we identify that sooner. Can we actually intervene? So if we can identify who's at risk, can we intervene and prevent evolution into Lennox-Gastaut? How can we reduce that diagnostic lag? We know that it takes time, too much time to get this diagnosis of Lennox-Gastaut. And so we need to probably work on defining that. How long is it actually taking for people to get this diagnosis of Lennox-Gastaut? And figure out how we can intervene. And that probably requires educating me and my colleagues so that we are making this diagnosis sooner. I think we've pretty much addressed how to diagnose Lennox-Gastaut. Again, we need to reduce this treatment lag. We need to figure out what our best treatment options are. We actually don't have any trials that compare different medications for Lennox-Gastaut. All of our trials are treatment and placebo, not one treatment versus another. And so we need to start looking at that a little bit. And I think Sandy Lamb is going to present a little bit of what her approach to that might be tomorrow. Does etiology matter? I'm pretty sure it does. But we need to define that a little bit more. Are patients getting the right treatment? We probably need to go back and figure out what's working and what's not working and how can we get you the things that are working faster. How do we measure outcomes? In our randomized trials, we're looking at seizure counting. But there's so many other things that are important to you, and we need to figure out how to measure that. And we also need to figure out how to measure it over a longer period of time without having somebody on placebo during that time period. And what are those most important outcomes? Seizures are at the top of your list of your concerns. So seizures are a good outcome, but there's lots of other things that we need to look at as well. And what do we do when your treatment fails? What are our next steps? And what are those out-of-the-box things that we can think about, such as DBS? So in summary, the takeaway points from all of this that I've tried to share to you today, the diagnosis of Lennox-Gastaut is an evolution, and it requires a provider to think about it. And that's a message that we need to continue to get out to our neurologists and our pediatricians that have you thought about Lennox-Gastaut? Are you thinking about it early enough? And what are you going to do to sort that out? Lennox-Gastaut is not a final diagnosis. It should always be secondary to something. And this is something that you, as families, can go to your provider and say, all right, I have Lennox-Gastaut, but why? Have we done everything that we can to figure it out? And the answer to that may be yes. But if you haven't, what are the next steps to figuring out why you have Lennox-Gastaut? I think it's also really important to keep in mind that this is more than seizures. We've talked about a number of comorbidities, and we need to figure out how to address these as well. There are lots of treatment options to think about, including some non-pharmacologic options, and we need to make sure that we're always thinking about treatment broadly. And keep in mind as families that at some point in time, you may need to try all of these options. The question when you're in the office is, what is the option that you're going to try now? What's the most appropriate choice for now? And those side effects need to be balanced to consider overall quality of life, not just seizure burden. And it will take a village. You probably need more than your pediatrician and your neurologist. And so you need keep that in mind as well. And I think that there truly is hope on the horizon. There's, bringing everybody together here is an amazing thing to do to get us talking and thinking about this. There's so much more research going into this. You are raising money to support that research. And let me tell you, I'm not a basic scientist, I'm a clinician, but I see my basic science friends, they go where the money is. And so if you are offering money to do research, they're going to shift their lab to do the research that you want them to do because they have to pay the bills. And so, that is a very helpful thing to do. And with that, I will take questions, I guess, or we're going to break, right? All right.
I'm not sure if I'm on here.
Yep.
Thank you, Dr. Knupp. That was fantastic.